Hello, and I want to welcome you to Drug Toolbox Online. Before we start, what I want to say is that you're going to hear a lot of repetition between each of the courses that you're going to be taking for your Fundamentals of Sedation Dentistry course through the American Seminar Institute. These are important points. I realize that I've covered them more than once. Bear with me on it. It's things and subjects and topics that I want you to make sure that you have locked into your brain. So, as I said, just please kind of bear with me on it. So let's go ahead and start Drug Toolbox Online. We have the disclaimer, which is with the other courses. As you know, that there's other sources besides me that you could seek and should seek if you have any questions, because people do things differently. This is the way that I was trained, and through my years of experience in nurse anesthesiology and as a dentist, that this is the way that I practice my sedation dentistry. Our learning objectives, we're going to look at describing the basic pharmacodynamics of each of the categories in the toolbox and those sedation meds that you will have. You won't have all of these, but I want you to know the names and at least to have seen them. Then we're going to go through the basic pharmacodynamics of the emergency medications. These you will probably absolutely have in your drug toolbox and in your emergency cart. We're going to develop a toolbox for your medication cart and your medication practice as a sedation dentist. And then we're going to assemble then the emergency cart. As you can see, we're going to go and look at the categories of commonly used intravenous medications. We're going to be talking about moderate sedation, deep sedation, and then general anesthesia. Let's look through each of these categories. Let's first talk about the benzodiazepines. And in that group, even though there's so many different benzodiazepines, the ones that you might be working with are Midazolam, Diazepam, Lorazepam, and Triazolam. So Midazolam is Versed, Diazepam is Valium, Lorazepam is Ativan, and Triazolam is Halcyon. Then there's the opioids, and there's many different types of opioids. We're not going to cover all of them, but I want you to at least, like I said, have seen the names. We've got fentanyl, Alfentanil, Sufentanil, and there's an oral form called Dsuvia that can be given. It's very potent. There's Remifentanil, morphine, and Hydromorphone. So Sufentanil is 100 times more potent than fentanyl, and it's 1,000 times more potent than morphine. Fentanyl is 100 times more potent than morphine. And I can tell you, when there was a fire at the fentanyl factory, this was back probably in the early 2000s, that we had to go to Sufentanil, and it has profound or knocking out breathing and really slowing the heart down because it's so potent. It's such a potent opioid pain reliever. Remifentanil is a drug that's mixed up in a syringe and has to be given through a pump, and it provides narcotic relief during the surgery, and it's metabolized by esterases in the bloodstream. Hydromorphone is a potent post-operative drug that we use. It's also called Dilaudid. Let's talk about the local anesthetics. Lots of different types. There's Lidocaine, Bupivacaine, Articaine that you're familiar with. There's one that you might not know about called Kovanaze. And believe it or not, in the operating room, we do use cocaine for nasal surgeries. We'll talk about those a lot more in depth. There's one antihypertensive drug that works solely at the arterial level, and that is called Hydralazine. Then we have the non-steroidal anti-inflammatory drugs, also called the NSAIDs. bunch of different types, but there's Ketorolac, Ibuprofen, Ketoprofen, and then Caldolor. We'll talk about those a little bit more in depth. We've got different types of vasopressors. You'll hear me say this again in the lectures, but when you see the word vasopressor, think of vaso or vasculature and pressing down on it. So if you were to take and crimp or crush down a hose, you know that it's going to shoot out further, so it's going to be under higher pressure. So these are stimulants for the heart and for the blood vessels to increase blood pressure. And those meds are ephedrine, phenylephrine, epinephrine, and norepinephrine. There's reversal agents, and we refer to those in a lot of the different lectures. There's naloxone and flumazenil that we primarily use in sedation dentistry. Antihistamines, there's two that I want to cover, diphenhydramine and famotidine. We've got one med, and you have to have a permit to be able to use at a certain level of anesthesia. That's a hallucinogen. It dissociates the body, the brain, from the body, and that's called ketamine. There's an anticholinergic. Two of them that we use in sedation dentistry are atropine and glycopyrrolate that you'll have in your drug toolbox. There's steroids. We've got several that we use: dexamethasone, Salucortef, Salumedrol. Then we've got some that just aren't classified, but that are important drug toolbox meds, and those are sugar, glucose, dextrose, and oxygen. We've got bronchodilators. There's albuterol and then Primatene Mist. Antiemetics, there's a bunch of different types, but we've got in our toolbox ondansetron, which is Zofran, dolasetron, granisetron, which are generic, but they're a little bit more expensive than the ondansetron, and then the scopolamine patch. We've got beta blockers that end in LOL, so we've got esmolol, labetalol, and metoprolol. Lots of others available. We've got just analgesics that aren't classified in any of the other classes that we have up above of drugs, but there's pain ease spray and acetaminophen, which is Tylenol. So let's talk more in depth about the benzodiazepines. The main focus for benzodiazepine use is to relieve anxiety. That's the only place that we use it in dentistry, other than, of course, if the person's having seizures. But primarily it's in our toolbox to relieve anxiety. And with a proper dose, it can produce amnesia. We don't guarantee amnesia when we're doing certain levels of dental sedation. The only time that it's guaranteed is during a general anesthetic. So it can produce amnesia, but do not promise your patient that they're not going to remember anything, because that just doesn't hold true. So if we looked at the depth of sedation, covering and talking about amnesia, we've got different levels. We've got minimal sedation, moderate sedation, also called conscious sedation. Minimal sedation is called anxiolysis. We've got deep sedation, analgesia, and then general anesthesia. And these depths of sedation, they move along a continuum. So you can go from one level up to another level and slide right into it, and your permit might not allow you to be able to treat that level of sedation. But you should be able to all rescue from the next level of sedation that you have a permit for. So if you've got a moderate sedation permit and you have a person slip into deep sedation and analgesia, then you should be able to, and you've got to be able to rescue them when they get into that deep sedation level. A continuum, as we said, it's defined as a continuous extent, a succession, or whole, no part of which can be distinguished from neighboring parts, except by arbitrary division. So if you go back and look at the continuum of depth of sedation, there's nothing that stops and starts. They just slide one into the other, and we reach that different level of sedation then. So with the level of general anesthesia, I just want to mention it again. We've already alluded to it in previous statements that I made, but general anesthesia is a controlled state of unconsciousness. So they are out of it as far as any thought processes going on, any cognition. So with that, since we've given them these powerful anesthetic medications, be they inhaled or IV or both, they can have partial and complete loss of their protective reflexes. So they're not able to withdraw from pain, they're not blinking, they're not swallowing, they may not even be breathing on their own. So they have lost a lot of their reflexes depending how deeply asleep we had them with a general anesthetic. So they may not be able to maintain their airway. They can't respond physically to any stimulation or verbal command. So if you weren't using local anesthetic with a person under general anesthesia and you wanted to extract a tooth, that brain of the patient is still going to sense the extreme pain from an extraction. So heart rate, blood pressure will go up. The patient might not move, but the brain still senses it. So we've still got to provide pain relief for them. And this is produced by pharmacological means. And they may not maintain their normal cardiovascular function until there's some stimulation. A lot of times their blood pressure falls and their heart rate falls because there's just no surgical stimulation to bring it back up to a homeostatic level. But the big thing here is number 7. Amnesia, meaning loss of memory, is guaranteed and implied. And in fact, if I promise a general anesthetic to a patient and they remember, I can be sued for that. I can be sued for battery. Just keep that in mind when you're talking to your patients. And that's the only level where, again, amnesia is guaranteed. So there's 2 types of amnesia. One is called retrograde, and the other is called anterograde. So if we look at an event starting like right now where we're at with me talking to you, retrograde amnesia talks about not even remembering coming, say, to your lecture today, turning on your computer, going to a physical lecture, any event leading up to now, you may have amnesia from that with certain drugs. The only one that I know of that does that is Ativan or Lorazepam. It can provide retrograde amnesia. Most of the benzodiazepines provide anterograde amnesia, meaning that starting now, if you give them the medication, they may have loss of memory from the moment you put the drug in their IV or they swallowed the pill. They may, as I said, it's not guaranteed, then have the amnesia from that point forward until the drug is metabolized and then excreted. So time is marching forward. Just make sure you know the difference between these 2 amnesias. I'm sure there's other drugs that provide retrograde, but I don't personally know of them. So you got to be really careful with a patient driving into the office. Hopefully they've got somebody that's going to be driving them, especially while they're on their benzodiazepines. And you may ask, well, there's people that take Lorazepam or Ativan just chronically to relieve amnesia, and it could impair their judgment. So I know that people live through life and drive and things like that, but just know that that should provide some caution for prescribing that to a patient and not having a driver there, just to keep them safe and to keep you and the patient out of trouble. Let's talk about the opioids. They are potent analgesic agents, so they're going to really provide pain relief. And we saw the list before. We talked about fentanyl, which is given IV. I know it's being used on the street now. We were taught that it didn't work in oral form, and apparently it's working in oral form for any illegal or illicit medications that the patient's taking. Alfentanil has got a really short half-life, and I'm surprised it isn't used more. It can be given IV. That's commonly the way we give it, but it just really isn't used. And it's something that you could check on if you don't want to use fentanyl. Fentanyl is probably the most common that we use in the operating room. We talked about Sufentanil, which is 100 times more potent than fentanyl, 1,000 times more potent than morphine. And in the battlefield, I know that the medics carry the lozenges that the person puts underneath their tongue for the excruciating pain during battle. Remifentanil we talked about early in the introduction. Morphine isn't a real potent analgesic compared to the others above, but it also releases histamine. So we just really don't use it that much. People get a lot of visual effects and hallucinations and things with morphine, so we just don't use it that much. But with post-op pain, it behooves you to use Hydromorphone and give that to the patient before they leave, especially if you've done a lot of surgery. It's dilaudid. It can be given IV, and it's just a nice, long-acting, potent analgesic. So these opioids are attached to opioid receptors, and again, they're just potent analgesics. I've listed here, nothing like this on the exam, but the different types of opioid receptors. The big one is going to be the mu opioid receptor. So just kind of look over the table and see what you see there. Just important to see that any of the opioids will attach to these receptors. The most commonly reported opioid-induced side effects are, and this is big, constipation, nausea, and vomiting. So I'm kind of hesitant to use large doses unless we're doing some pretty painful surgery for the patient. It can cause pruritus, which is going to be skin itching, and diaphoresis, which is sweating. And this is especially seen with morphine, where you have the histamine relief. But you're going to start to see such things as sedation and fatigue. Sometimes it provides some effects that we don't like headache, delirium, confusion, clouded vision, and dizziness. They can provide also dry mouth or xerostomia, bladder dysfunction, and postural hypotension. So if you were to bring them into an upright posture or a sitting up, they may not respond by bringing their blood pressure up, and they may pass out, get nauseous, and stop breathing, whichever, during some of the side effects from opioids. Remember to carefully titrate your medications. And they will work synergistically. They'll work right alongside the non-opioid analgesics. And it's a great idea to start learning, if you're not already using them, for pain during the procedure and pain for the post-op procedure. And we're going to talk about a bunch of those in just a little while. So you might be able to then use a lesser dose of an opioid, or if you're using a narcotic, you might be able to use a little less benzodiazepine to provide them some amount of relaxation and sedative effect. Let's talk about the local anesthetics. I won't go real in depth with this because we had a ton of this in dental school, but I want to review some important points with you with the local anesthetics. We've got all the different types, as you can see, Lidocaine, Bupivacaine, which is more fatty soluble and it has a longer half-life. Articaine, Kovanaze, we'll talk about that in just a bit, and again, cocaine. So what you've got with the local anesthetics is that they are sodium channel blockers. You've heard about calcium channel blockers, but local anesthetics are sodium channel blockers. And as the myelin wraps around the nerve, the axon, you'll see that there's a sheath there. It's called the Schwann cell, and it has a node in between till the next Schwann cell picks up. So we've got to block with our local anesthetic 3 of those gaps. Those are called nodes of Ranvier, and we've got to block at least 3 of them to get a good, potent, effective local anesthetic. So the conduction of the signal across the nerve or along the nerve is called saltatory conduction. It will go from node to node to node to node. Kovanaze, as I said I would talk about a little later, well, later is now, but it is a mixture in a spray form of tetracaine, which is an ester local anesthetic, and oxymetazoline, which is a nasal decongestion. It's the main component of Afrin nasal spray. So it's given intranasal, and you can see in the picture, it goes through the nasal mucosa and it will anesthetize the facials of numbers 6 through number 11, facial only, so labial only, no lingual local anesthesia, without any kind of a needle if you need that for your patient. If you're not taking out a tooth, then you're not going to really need to have much in the way of palatal anesthesia. But it's nice. Unfortunately, it's pretty expensive still for the patient that is going to have some dental work done on their anterior teeth of the maxilla. And then there's pain ease spray. We'll talk about this later, but it also is just ethyl chloride that evaporates, and it will provide a real quick temporary numbness to the skin. So remember this, because we're going to talk about it toward the end of this course. It's a nice spray if you're starting IVs and you don't want to use subcutaneous lidocaine. This is what we use when we're teaching anesthesia IV inserts to students, and it's great for the patients, but you've got to get on getting the IV in, have everything ready so you can insert the catheter, hook it up, get the drip going, and then tape it down. Let's talk now about the antihypertensives. There's only one that is reliable, and it's fast, and it's just absolutely a nice antihypertensive, and that's hydralazine. And it just relaxes the arteriole. And as you will remember from some of the courses you might have already taken or that you're about to take, that the arteriole is the physiological location where blood pressure is determined. So if that is squeezed tight, blood pressure is going to go up. If it's loosened, then blood pressure is going to drop. The arteriole is the location just before we split into capillaries that contact every cell in our body. The blood and the waste products are brought into the capillaries again and then taken away through the venule and then into the venous system, and then we'll excrete it or exhale it or whatever. So the tension and relaxation of the arteriole is the primary determinant, as we said, of blood pressure. Important point to know while you're doing clinical sedation and anesthesia, that you should know about this drug and become really familiar with it. So what it's doing is it's taking a noose, if you will, around the arteriole, and it's loosening it so that there's room so that blood pressure drops then. This drug, hydralazine, comes, as you can see, as 20 milligrams per milliliter. I would dissolve it in one of your syringes with, if you have 1 milliliter of this drug and it's 20 milligrams per milliliter, and then just go into your IV solution, pull out 3 milliliters. So that'll make 4 milliliters of drugs, and then that comes out to 5 milligrams per milliliter. If you need to, pause your recording, grab a piece of paper, and just see that 20 milligrams in 5 milliliters is going to be 4 milligrams per milliliter. I should have said 20 milligrams in 4 total milliliters is 5 milligrams per milliliter. Sorry about that. You could have caught me right there. So it has to be single diluted. Let's talk about the non-steroidal anti-inflammatory drugs. And as you can see from this slide, there's a ton of them. And a lot of them are on television. There's a lot of ads for them. And Aspirin is probably one of the first NSAIDs ever invented. I know that it was invented by Adolf von Baer, and that's where Bayer aspirin comes from, back in the late 1800s. So just see these. Notice that Advil is ibuprofen, and there is an IV version of it now. Some, like Mobic on the right, are really potent NSAIDs. So just to show you so that you can see that you can keep up with things, there is IV ibuprofen now, and I encourage you to read the drug handout and look in your book, like your lexicon pharmacology book, which I really encourage you to get. It's a big, thick paperback book, comes out every year. You don't have to buy it every year, but it will give you the fountain of knowledge that you're going to need with all the different drugs you're going to be using. And then out for a lot of years was Toradol or Ketorolac, which is now in a generic form. So 30 milligrams of Toradol IV is equivalent to 10 milligrams of morphine. So that is some nice pain relief without the side effects of having to give a narcotic. The Caldolor is given through a drip in with the IV. And then Ofirmev was available for years in Western Europe. It's just Tylenol, if you will, acetaminophen dissolved in liquid, and is given then through the IV. And Tylenol itself is a great nonsteroidal anti-inflammatory. Let's talk now about the vasopressors. There's that diagram. I'd really like to see you memorize it, of the arterial, the capillaries, and the venules. Notice that the capillaries, as they split into finer and finer channels, are talking to each of the cells. They're talking with the fluid between the cells, the interstitial spaces, but there's a lot of exchange going between the cell and then back into the capillary. So just notice that. Please memorize that diagram. It's going to be helpful with you with a lot of the different drugs you're using in sedation dentistry. So some of the vasopressors that we primarily use in sedation dentistry are going to be ephedrine, epinephrine, and phenylephrine. So if we look at the arterial again, you're going to know that if you apply tension to that arterial with one of the medications, any of the ones that we just talked about, the three primary ones that we use in sedation dentistry, again, the ephedrine, epinephrine, and phenylephrine, that it's going to tighten that noose, so you're going to increase blood pressure. And if you look at the hose, like we talked about earlier, if it's flowing like normal, then you see the flow there on the right. But if you squeeze it and tighten the noose, if you will, on that hose, it's going to be under a lot more pressure. It's going to squirt way out into the yard or wherever. Again, vasopressor is pressing on vaso. So you're squishing down the tubing and you're going to increase blood pressure. So you're probably wondering, why are these the three that we've talked about? Well, the important thing to know about each of them, first of all, is let's talk first about ephedrine. Ephedrine both increases blood pressure as a vasopressor action, and it increases heart rate. It indirectly releases norepinephrine. So you're going to increase heart rate and blood pressure with that. And if you keep giving this repeatedly to the patient, they develop something called tachyphylaxis. Tachyphylaxis, tachyphylaxis. They will become less responsive to the drug ephedrine. So just know that that's there. It has to be single diluted, the ephedrine. So there's 50 milligrams in that vial that you see there. We dilute it, that 1 milliliter, with 9 milliliters of IV solution, and that makes 5 milligrams per milliliter, and that's how we dose the patient. Phenylephrine is used to increase blood pressure, so it's going to work on tightening the noose, but it produces no effect on the heart. So when the heart and the cardiovascular system sees the pressure go up, the heart rate reflexly goes down. So let me say that again. We're going to go ahead and we're going to increase blood pressure with phenylephrine. We're going to have tightened the noose. And as a result, the body reflexly says, I don't need to be beating the heart this fast and keeping the blood pressure up. It's up. So the heart rate is going to go down. So we don't have the cardiac output, which would, when it was high, raised blood pressure. So there's a reflex drop. And then lastly, we talked about epinephrine. And the only place that I've ever used epinephrine, and again, it's extremely rare, I hope you never go through it, is with the patient that's experiencing a cardiac arrest. It's part of the ACLS algorithm. Let's review again the fundamentals of the autonomic nervous system to explain some more about some of the meds that we're going to be talking about. I know you're going to have seen this in other lectures, but just as I said, bear with me. It's important to know, make sure you know this so that you know how these meds are working. And it helps you to remember then how to use them. So we talk about the autonomic nervous system, the automatic nervous system. There's the parasympathetic side and the sympathetic side. Parasympathetic side uses acetylcholine as the neurotransmitter, and norepinephrine is the neurotransmitter on the sympathetic side. And these two systems counterbalance each other. When one needs to be in effect, the body automatically uses it and releases that neurotransmitter on either side. So the sympathetic side is going to bump up such things as heart rate, blood pressure, going to get you ready to run away from that saber-toothed tiger. It's going to decrease urine output so that your body is in total focus and is not digesting food or lounging and relaxing, which is going to be more the parasympathetic side. That's where we're going to see the slowing of the heart rate. We're going to see the stomach emptying, the colon, the digestive system doing its thing, and just relaxation, digesting, getting things done. The total opposite of the sympathetic side. So any of these drugs that we've talked about mimic norepinephrine. So they're called sympathomimetics. Even though they're not the same molecular structure, they mimic the effects of the norepinephrine. So these are some of our vasopressors. And again, ephedrine, epinephrine, phenylephrine. Different molecules, but produce that same effect as norepinephrine does. We're not going to see the increase in heart rate, as I said, that we saw if we give phenylephrine, but we will see that because of the mimicking with ephedrine and especially adrenaline or epinephrine. So just look through these slides, look to see what these drugs do. It's something that we talked about a little bit earlier. I'm talking about ephedrine, epinephrine, and phenylephrine. At the end of the lecture, you're going to see a recipe on how to single dilute drugs such as ephedrine. We talked about that with hydralazine. And phenylephrine has to be double diluted in the syringe. It's too potent. There's 10 milligrams per milliliter there. I think that you would have something like cardiac shutdown if you were to give that whole bolus of that medication. Really dangerous to do that because it's so potent. It has to be double diluted. And in fact, right here is the appendix. You can see the diagram for how to do that, where you would draw up the milliliter of the drug, draw up 9 milliliters of the fluid, and then you'll have 5 milligrams per milliliter. So you will have this as part of your algorithms that I gave you for emergencies, and you'll have this in some of the other notes that you've gotten for some of the other classes that you're taking with us for your fundamentals of sedation dentistry. So for phenylephrine, the double dilution recipes, you're going to draw up that 1 milliliter, that 10 milligrams of the phenylephrine, go into your IV, draw up 9 milliliters of fluid. So that's going to make then the concentration in your syringe of 1 milligram per milliliter. Then we're going to spray out into a trash can or whatever, it could be in a sharps container, whatever you want to do. You're going to squirt out all but 1 milliliter. Don't squirt it all out. You're going to squirt out all but 1 milliliter. You could do it into a paper towel. So you'll have now 1 milliliter or 1 milligram of phenylephrine available. You'll go back in for the second time, pull out 9 milliliters, and that's going to make the phenylephrine now 100 micrograms per milliliter, and that's how we dose it for the patient. Epinephrine, if you're going to use it not in an ACLS effect, also has to be double diluted if you want to use it as a vasopressor, but we just don't use that. It's used straight for ACLS. We don't really use that in sedation dentistry, but know that you can. You're going to have some real potent effects with epinephrine, and it's got an extremely short half-life because the body's designed to go ahead and to neutralize that molecule as soon as possible. So make sure that you can calculate the final concentration of those medications and accurately then label your syringe. Let's now look at the parasympathetic side of the system. With this side, we're not giving acetylcholine, but we've got some drugs that mimic or block acetylcholine, and they're called parasympathomimetics. And they're going to really function more not to mimic acetylcholine, but to block its effects because it has such potent effects on the heart, especially. More specifically, any drugs that block the effects of acetylcholine are called anticholinergics. And there's two that we use in sedation dentistry quite often, and those are atropine and glycopyrrolate. Remember, if you look at the anatomy diagram, you're going to see that it has effects on the heart. And you can see that it is also attached to a number of organs. So if those organs are tugged, you could produce a profound bradycardia in the patient. So the drug that I have found the best for that, and of course you're not doing any eye surgery, but if the ophthalmologist is putting a suture in the eye and tugging the eye to the side, there's something called the oculocardiac reflex, and the heart will brady down to levels where I've seen it nearly flatline. I've seen it at levels of 27 beats per minute, and I tell the surgeon to let up. I give the atropine. It's going to circulate slowly if their heart rate's beating at 27 or 30 beats per minute, but then you'll see it block the cholinergic receptors at the heart, and the heart rate will go up, and then blood pressure will come up. The other anticholinergic is going to be glycopyrrolate, and it too will function for bradycardia, but it's also something that is just wonderful if you're going to be doing a lot of dentistry in the mouth. It's called an anti-sialagogue. So it's going to really dry up the patient's mouth. And I usually give the dose of 10 micrograms per kilogram for that. It's just a really small dose of glycopyrrolate. And it doesn't affect right away, but you'll gradually see their mouth become just as absolutely bone dry, and it's wonderful to work on dry mouth. We talked about it, the anticholinergic for the vasovagal response. We'll have talked about that in other lectures, but you'll see them get lightheaded, pale skin, develop hypotension, bradycardia, tunnel vision, nausea. They'll probably tell you that they've got this coming on before things get really bad. They'll start to slur their words, cold, clammy, just a cold sweat. They might feel warm, vision blurs if they're having a vasovagal response, which is going to be a response that the vagus nerve is working on overdrive, and the patient is more than likely going to go ahead and pass out. So we would give one of our anticholinergics here, either atropine or glycopyrrolate, open up the fluid, get it in line, and give that. And as I said, it's a great anti-sialagogue. Let's talk about our reversal agents. And we've got two that we use in sedation dentistry. There's naloxone, and then we've got flumazenil. The naloxone comes 0.4 milligrams per milliliter. So if you single dilute it in a 10 milliliter syringe, you're going to end up coming out with 40 micrograms per milliliter, and that is the way that we administer it to the patient. The naloxone, unless it's an emergent situation, is given straight from the bottle. But if you're reversing narcotics in sedation dentistry, which I'm hoping you don't use these too often because you're titrating your narcotics in all your sedation medications, just use it that way. You can see it's for IV, IM, or subcutaneous use. Flumazenil for adults is usually 1 milligram per milliliter, and that's given straight from the bottle. The 0.5 milligram per milliliter, I just like to let you know, that is 0.5 milligrams per 5 milliliters, so it's 0.1 milligram per milliliter, is used for pediatrics. So we're going to titrate naloxone to reverse the opioid side effects. But then don't forget, if the opioid is gone, the person's going to have extreme pain if they've had surgery and such, and they're going to go through the terrible withdrawal symptoms. Again, flumazenil is used straight from the bottle, and you have to be worried about such things as the half-life, which is really short for flumazenil. And we see that in this slide with these different cones. The half-life for flumazenil at the top is really slow. So if you're giving Versed or the person's taken Lorazepam or Ativan, reversal may reach its half-life before the dose is gone, if you will, from the metabolism of the Versed. In the case of Triazolam, they might still be sedated with it. So again, just reviewing, be careful using naloxone. They're going to have extreme pain and a rebound effect because of the opioid. Again, rarely use it. Flumazenil, you might want to give that to certain patients. Just realize that it is got a really short half-life. Remember, half-life is the amount of time it takes for the dose that you originally gave to be half gone. So the amount of time it takes to reach half the dose you gave is the half-life. Let's talk about antihistamines and the allergic response. We're going to talk about this lots more in some of your other lectures. Here's the different allergens that people can come across. The mast cells and the basophils have IgE attached to them, and there's granules of these antibodies from the B lymphocytes in your system. When they are stimulated by an antigen, there's some nasty chemicals that pour out. Mast cells are found in the connective tissue, and basophils are circulating in the blood. And those nasty chemicals that come out are histamine, especially serotonin, bradykinin, and heparin. So the things that we'll see are going to be, again, skin itching. We're going to see rash, lip swelling, edema of the lips, edema of the tongue. There goes your airway if this swells real quickly. So you're going to have to do rescue breathing. You may have to use an advanced airway device like an LMA or an endotracheal tube, or if worst is worse, then an emergency cricothyroidotomy would have to be done. They're going to get bronchoconstriction, upper airway obstruction because of the swelling, and if it's a potent anaphylactic reaction, they're going to die almost immediately from that reaction. Fortunately, that's extremely rare. So we've got the antihistamines, Benadryl, and we've also got famotidine. We put Benadryl out from our mast cells and our basophils, as we said. We put out histamine. So if you give Benadryl, that's going to take care of a good part of the histamine that's outpouring. So it's a histamine blocker. It's not covering everything though, because histamine also comes as a result from the GI tract, the gastrointestinal tract. So we have to give famotidine then to the patient. So that has to be in your drug toolbox. And you have to give that IV. You just give the whole 20 milligrams for that. For the diphenhydramine or Benadryl, that's a part of a lot of sleeping medications, and patients will become sedated with that. So you got to be really careful titrating that, but it's pretty much an urgent situation if they have an allergic response. So just be prepared to support the airway and blood pressure while the patient's becoming sedated from the diphenhydramine or the Benadryl. As we said, it's a part of a lot of nighttime cold medications. We used to have ranitidine that was used for us, but in April of 2020, it was determined that it was a carcinogen. So if you have that or you see it, don't use it. It's not available in the United States. It was also an antihistamine for the GI tract. The other meds that we would use, our primary med that we would use would be hydrocortisone. I know you're going to want to jump to the antihistamines, but you're also going to want to give your Cycortef. That is probably your drug of choice. It stabilizes the membranes and it is a steroidal anti-inflammatory. And then no one said that one of your assistants or somebody else can draw up your antihistamines right away. And lastly, epinephrine is going to increase heart rate and blood pressure in an extremely urgent or emergent situation. So the goals of treatment are to counteract the massive release of histamine. The big thing is to start with the steroid, move to the antihistamines. We're going to want to reestablish blood pressure. We have got to get blood to the brain. All the major organs need their blood supply. And then lastly is going to be the airway and the breathing. I always call 911 for an allergic reaction. It depends on the severity of the reaction, but you have got to get on treating these patients. This movie, and you'll see this in one of your other courses from us, shows you how to mix the Cycortef, your first drug of choice. It's got water at the top, it's got a rubber stopper in the middle, and then it's got hydrocortisone powder in the bottom. So take a look at that movie. We're not going to talk real long on the hallucinogen, but it's a wonderful drug. It's a dissociative anesthetic invented by Dr. Calvin Stevens. I believe it was created in the 70s. But what it is we would titrate it in, and it actually removes the person's cerebrum chemically, if you will, from their body. So you see the person on the right staring straight ahead. They're still breathing on their own. It doesn't knock out breathing. It causes them to salivate, but it absolutely takes them out of the picture as far as any consciousness or anything like that. Talking, it's just kind of a blank stare straight ahead. Now there's some pretty bad hallucinations that the patient can have. So we always give this either with propofol, if you can use that, or give this along with benzodiazepine because of the severe hallucinations that some patients can have. This is in the same class of medications as angel dust. So some pretty potent, crazy hallucinations can occur. It doesn't have a reversal agent, so it's not one of our drugs that we would use unless you have this level of permit. So look at the picture of the two ladies. The one on the left is the lady that's had the drug. The one on the right is the normal awake patient, and the person's just totally out of it. They're dissociated from their environment. We've already touched on this before, but let's talk again about the steroids. The one that you're going to commonly have in your drug kit is Cycortef or hydrocortisone. The other that you could have that's more potent is methylprednisolone, and you can see they're in the same type of bottle that has to be squeezed together. The liquid is mixed in with the powder, and then that little cap at the very top there, you flick that off with your fingernail and then turn the bottle upside down and draw your med out of it. And then another potent steroid that is an excellent anti-emetic, an anti-throwing up drug that I have in my kit, it's wonderful, is dexamethasone. It's inexpensive. It's a real potent steroid for patients that are having, say, the allergic reaction. And you could see these are some of the uses for the steroids in sedation dentistry. It is an anti-inflammatory, a steroidal anti-inflammatory. It's used for oral inflammation. It's used in anaphylaxis, along with the other drugs that we talked about, the epinephrine and the antihistamines, diphenhydramine and famotidine. It's used in mild allergic reactions. It's a potent anti-nausea medication, and it does provide some sedation. So just be aware of these drugs and use for that. The anti-nausea part is going to be your Decadron. It works great for that. And you can use that in conjunction with a drug like Zofran or ondansetron. We're going to talk about some other medications that we've got for the patient that should be in your drug toolbox to be able to help treat some aspects such as low oxygen, hypoglycemia, and such. So some of the causes of hypoglycemia are just following the NPO guidelines. If they follow them right, they might have, and they probably will have, hypoglycemia, which is going to be defined as less than or equal to 55 milligrams per deciliter of glucose in their bloodstream. And while you're putting in an IV on a patient, it's good to run a point of care test with your glucose monitor that you'll also have in your emergency drug kit. So a diabetic patient that's taking their insulin or their oral hypoglycemic may have low blood sugar. A person that's taking and using a certain kind of diet could also have hypoglycemia. Excess physical exercise, you may have depleted a lot of sugar in the bloodstream, and patients will have that. And then from chronic alcohol use, you're going to drop your blood sugar. So some of the signs and symptoms of severe hypoglycemia are going to be shakiness, dizziness. There could be cold sweating, hunger to even food and drink, a fast heartbeat, especially if they've been NPO. They can't concentrate. There's just not enough glucose going to the brain for it to function properly. So along with that, you'll see confusion, irritability, moodiness, anxiety, nervousness, headache, clumsiness or jerky movements, just from all the low blood sugar going to the brain that's commanding a lot of blood supply and a lot of energy. They'll have muscle weakness, slurred speech or difficulty speaking, blurred or double vision, drowsiness, confusion, all the bad things, convulsions and seizures if it's really severe, may drop off unconscious, and in a severe state, it is extremely rare that death would occur. One of the other drugs that you'll have in your drug kit is going to be dextrose. So make sure you have a bottle of that in your drug kit, in your emergency kit. If you've got an IV in the patient and you're doing an IV anesthetic and they start to have some of the symptoms we've talked about, then you're going to want to go ahead and squirt that D50, that whole bottle, into their IV fluid and let them get their glucose that way. It's actually dextrose, which is glucose and galactose. So they're going to get their glucose that way. There's glucose tubing that you can get with just pure glucose, but even cake icing just at any grocery store might be a more cost-effective alternative to that. Or just chewing on or soaking up some really sugary candy or a sugary soda. So with oxygen as one of our other drugs, we're going to boost the FiO2 of the patient especially one that might be going through one of our dental emergencies. So you've got oxygen there as one of your other tools in your emergency armamentaria. We'll talk about this in some of the later lectures or some of your other lectures, but we've got two bronchodilators. One you may not have in your kit and somebody might not have talked about too much, but you've got Ventolin, which you should have, and that's albuterol, and one that you can get over the counter that is used to treat bronchial asthma is racemic epinephrine, also called Primatene Mist. I would have both of those in your kit, and I know that in a lot later in one of your other lectures, we're going to show you how to properly use those inhalers. So we want to have nice opened bronchial tube linings. We don't want anything that's going to spasm, have any secretions or something so that the patient isn't air hungry or going through that and not able to move air and their sats are dropping. There's a list right here of the treatment for asthma bronchospasm. I'd like you to take and look and read through each of those. We talked about using it, and you're going to get the same thing again in your emergency medications every dentist should know lecture. So take and read that over. And the next slide for properly administrating an inhaler to a patient. Let's talk now about the antiemetics. We have several intravenous ones, and you'll be surprised by one of the other ones that we use that are in our drug toolbox, in our arsenal that we use for the different medications. The one that's most common and probably the least expensive because it's become generic and it comes in a multi-dose vial now is going to be ondansetron. And it comes 2 milligrams per milliliter. Typically, we use 4 milligrams, so 2 milliliters of the drug IV for nausea. It's a great prevention tool, too. You don't want your patient to develop nausea and vomiting as they're riding their way home in the car or at home, relaxing on the couch or in a chair or in bed or whatever. It acts, the ondansetron, by going to the vomiting center and blocking those nerves. And specifically, it's the 5-HT3 receptors. So it blocks those, and it blocks then parasympathetic activity that can lead to nausea and vomiting. We don't really know why, but again, as we talked about a little earlier in the lecture, Decadron or dexamethasone, just 4 milligrams, you can give up to 8 or even 10 milligrams, is a great anti-inflammatory, and it's also a great potent anti-nausea medication. It's an antiemetic. We don't know how it works, though. I know that it's speculated and it says here, but I've not really heard it taught. I tried to look up to see what it was. They're saying that it goes to the Tractus solitaris, and I have not really heard that much. I know that this is research that's going on. So it blocks serotonin administration. Take that for what it's worth. Just know it's a great antiemetic. The thing that you're going to be probably most surprised at is, as a rescue medication, that alcohol wipes are great rescue medication. So if you quickly grab a couple of these, rip them open, have the patient take some deep breaths. If they've got a nitrous mask on, turn off the nitrous and let them take some really big deep breaths. It will counteract them building up through the nausea, the beginnings of heaving, and then the eventual throwing up. It just stops it in its tracks. Again, I don't know how that works. We've got then our beta blockers. In your other lectures, you're going to hear about these, but beta 1, the receptor for that increases heart rate. Beta 2, once it's stimulated, it will relax the bronchioles. It doesn't cause them to constrict. It also works on vascular smooth muscle, relaxes it, and it relaxes the uterus, but we're not using it for that. So your beta blocker drugs are going to be the LOLs, and those are esmolol, labetalol. There's also a drug called metoprolol that's got a much longer half-life. I like using esmolol because it works very quickly. It has a short half-life, but it's metabolized in the bloodstream by esterases, so it's gone very quickly. So with the beta blockers, you give those because it's going to block beta 1, which once it's stimulated is going to increase heart rate rapidly. So if you're nervous or you see something that's emergent or painful, your beta 1 receptors are being stimulated like crazy. So if we block those, heart rate's going to slow down and then blood pressure is going to slow down. And unfortunately, the beta blockers will also stimulate beta 2. It doesn't differentiate between the two. So as we see, it relaxes bronchioles. So you're not going to want to give a beta blocker to a patient that's an asthmatic or having some trouble breathing. Because if we need to rescue them, they need to have beta 2 being able to be stimulated. So one of the first things I always ask every time I decide I want to use a beta blocker is to know that I'm not going to give it to them if they're an asthmatic. So here again are the 3 adrenergic receptors. The betas are going to be blocked by the beta blockers. Alpha blockers, we've got other meds that will block alpha 1. So once alpha 1 is stimulated, it causes vasoconstriction. So we talked about then the drug Hydralazine that's going to relax alpha 1, and we've got drugs like our vasopressors that are going to artificially stimulate alpha 1. Alpha 1 is involved with vasoconstriction. Beta 1 increases heart rate. So again, if we block it, we're going to slow the heart rate down and then blood pressure is going to drop. Beta 2, it's really our friend, so we don't want to mess with it. And we're going to want to make sure that we're not blocking it because it dilates the bronchi so that the patient can breathe. And here's just a summary of those 3 adrenergic receptors. Just look through and be familiar with beta 1s, beta 2s, what blocks it, what stimulates it. And again, here is our drug toolbox. Lastly, we've got Ofirmev, which is, as we talked about earlier, IV Tylenol and pain ease spray, which we also talked about earlier for starting an IV and such. Since I wrote this lecture, there's been some new developments which are really interesting and I wanted to share with you before we close out this session. So I'm going to add this addendum to your lecture. This is the sedation toolbox that I first presented at the beginning of the lecture. It is going to be the old drug sedation toolbox. So I want to show you what I did with it. First thing I did is we're going to remove ketoprofen. Ketoprofen was called Orudis and it was taken off the market. It caused strokes and heart attacks. So we won't promote that anymore. It was available over the counter and it's not available anymore. And if you look at the benzodiazepine column, we see Midazolam, Diazepam, Lorazepam, and Triazolam, but we've added a new drug and it's called Remimazolam, and I want to talk to you about that. Remimazolam has just come on the market, and what it is it is a powder that is 20 milligrams in the vial, and it's called Bifavo. And the way that you mix it up is you'll take a 10 cc syringe, draw out some of your normal saline, you can't use LR with it, inject that into the bottle, so it's 20 milligrams in 10 milliliters, so that makes 2 milligrams per milliliter. And this is how you dose Remimazolam. You would go ahead and give about 2.5 milliliters or 5 milligrams. I probably wouldn't go too much over that with moderate sedation, and you can titrate that. You can start with the 2 milligrams and see how that affects the patient. And in order for you to have moderate sedation, I know that that's not on this list. You're just going to have to titrate it. You can see the dose that the manufacturer has presented for 5 to 10 milligrams to get deep sedation. So I encourage you, and I really want you to stay within the realm and whatever the parameters are for your particular anesthesia permit. So who are the ideal patients? You can use these for sicker patients. Now I realize that in the dental office you're going to be seeing probably physical status or ASA physical status 1s and 2s, but I just want to show you that it is really good to use this on 3s and 4s, and I'm going to show you why in just a little bit. It's good to use on patients that are cardiac compromised. We're looking at things like ejection fraction. Normally that's around 70, 75, maybe 80% of the ventricle is emptied. It's used for aortic stenosis patients, high-risk patients, the morbidly obese or the severely obese patient that's called now, your patient with breathing difficulties, COPD, which is chronic bronchitis, asthma, and emphysema. So the asthmatic patient alone would be a good patient for this. And the geriatric patient. Normally I didn't like using a benzodiazepine with a geriatric patient because, as we can see, there's metabolites and the drug hangs on, and in an older patient it can really leave them with some dementia for a period of hours, days, weeks. And so we just didn't really use it for geriatric patients. Or if we did, it was in an extremely light dose. But you don't have to now when you're using Bifavo. So the reason that this is such a great drug is that you can see that the molecule of Midazolam, when it's broken down in the liver, it has 2 active metabolites. And those will, of course, cause that sedation for a long period of time, which is probably about 2 to 6 hours. But your older patients, remember, with the impaired circulation to their liver and their required lesser MAC dose, will have this midazolam or Versed hanging on. With Remimazolam, it is broken down by a tissue esterase, and there are a number of them in the bloodstream, and they're non-specific. So it comes along and it catalyzes off, or it breaks off this green molecule you can see there, and it turns it into a carboxylic acid that is inactive. So even though the molecule's there, it's inactive in the bloodstream, and that's really a nice thing. So it is inactive, it's gone. I just wanted to show you, we've talked about this in earlier parts of the lecture, but Diazepam is broken down, just wanted to show you, as a metabolite, Nordiazepam, Temazepam, and then Oxazepam, and those are all active. That's why we've got a 24 to 48 hour prolongation of Diazepam being in the bloodstream and circulating to the patient's brain and then having effects. So there is a Starbucks, Versed, ketamine, mocha, almond, whatever drink. So relax. Thanks for taking and listening to this lecture.